Just a very quick information for those who have registered for the workshop. As soon as Professor Alagesan sir has finished his talk, I request all of you to head to first floor so that the workshop things are getting ready, so we can start off with the workshop on time. Thank you.
Now I call upon Professor Dr. Alagesan sir to give a talk on the current concepts of pulmonary hypertension by echocardiography. Sir is a retired professor and head of Department of Cardiology in Madras Medical College. He is Emeritus Professor, Tamil Nadu Dr. MGR Medical University. He is a past president of Indian Academy of Echocardiography. He has authored more than 50 peer-reviewed publications, and he is the recipient of Lifetime Achievement Award from the Indian Academy of Echocardiography. Over to you, sir.
Thank you for the introduction. The topic is pulmonary hypertension. I want you to, most of the people who do echocardiography, they mention pulmonary hypertension as just a finding. Pulmonary hypertension present, mild, moderate, severe, and all that. I want all of them to look at the TR tracing at least and see whether there are any associated findings before they decide. So the talk is mainly towards tuning you to see the other parameters also before you commit that is pulmonary hypertension. So this is based on the 2018 guidelines, NICE guidelines on pulmonary hypertension. What is new and revisiting the role. Why pulmonary hypertension is important? Because pulmonary hypertension is responsible for the symptoms and disability. And it is responsible for hemodynamic consequences. Suppose it's especially in patients with lung disease or systemic lupus, etc. Presence of pulmonary hypertension carries a lot of prognostic importance. And management decisions are often based on presence or absence of pulmonary hypertension. For example, if you say, take a case of mitral regurgitation, severe mitral regurgitation, if the patient doesn't have pulmonary hypertension, we may wait. Or if the patient has pulmonary hypertension, it is an indication for mitral valve replacement or repair. Look at the normal pressures. The right atrial pressure is about 0 to 7. The right ventricular systolic pressure is about 15 to 25, and the diastolic pressure is about 3 to 12. The pulmonary systolic pressure is equal to RV systolic. The diastolic pressure is about 8 to 15. 4 to 14. The pulmonary capillary wedge pressure is about 6 to 15 millimeters of mercury. Non-pulmonary pressures. So here look at the mean pulmonary pressure, which will be talking about again and again. Hello? Okay. So the mean pulmonary pressure is the most important one. Say any pressure below 15 is clearly the mean pulmonary pressure is normal. So according to the guidelines, before the 6th symposium, the pulmonary hypertension was referred to as any pressure which is equal to or more than 25 millimeters of mercury is pulmonary hypertension. Any pressure which is below 20 millimeters is normal. Between 20 and 25, we don't know. It is a gray zone. In patients with pulmonary arterial hypertension, the pulmonary capillary wedge pressure and the LV end diastolic pressures are always normal. This is pulmonary arterial hypertension. The pulmonary capillary wedge pressure, edge pressures, end diastolic pressures are normal, and it is less than 15 millimeters of mercury. And the pulmonary vascular resistance is increased, and it is usually more than 3 Wood units. So according to the 2018 updated guidelines for pulmonary hypertension, the conference was held at NICE in 2018, the guidelines were changed. Instead of the cutoff of 25 millimeters of mercury, the cutoff is about 20 millimeters of mercury. Any mean pulmonary artery pressure more than 20 millimeters of mercury is pulmonary hypertension. It can be either pulmonary arterial hypertension or pulmonary venous hypertension resulting in pulmonary arterial hypertension. So all the group, if the pulmonary artery pressure is more than, mean pulmonary artery pressure is more than 20, it is called pulmonary hypertension. The precapillary hypertension or the, pulmonary arterial hypertension, apart from the mean pulmonary artery pressure, the pulmonary artery wedge pressure and the wedge pressure is normal, less than 15 millimeters of mercury. And the pulmonary vascular resistance is increased and it is more than 3 Wood units. So this here happens in some of the groups, 1, 3, and 4, and 5. We will come to the groups as such. Then isolated post-capillary pulmonary hypertension, that is pulmonary venous hypertension, occurs in groups 2 and 5 when the mean pulmonary artery pressure is more than 20 millimeters of mercury and the pulmonary artery wedge pressure is more than 15 millimeters of mercury and the pulmonary vascular resistance is often normal. In this isolated post-capillary pulmonary hypertension itself, there is a group of patients who develop precapillary component also. This can be identified by a diastolic pressure gradient of more than 7 millimeters of mercury, and the pulmonary vascular resistance again is increased in these patients. So these patients have both precapillary pulmonary hypertension and post-capillary pulmonary hypertension, and this can happen in group 2 and 5. So if you see the groups, say all the patients have pulmonary hypertension more than 20 millimeters of mercury. That is, the first group is pulmonary arterial hypertension. The second group is pulmonary hypertension due to left heart disease. The third group is pulmonary hypertension due to lung disease. The fourth one is chronic thromboembolic pulmonary hypertension. And the fifth one is pulmonary hypertension with unclear and multifactorial mechanisms. So in all the patients, the pressure is more than 20 millimeters of mercury. The pulmonary artery wedge pressure is normal in 1, 3, 4, and 5. So this is the group in which the pulmonary artery wedge pressure is normal, pulmonary vascular resistance is increased. The post-capillary pulmonary hypertension, where the pulmonary artery wedge pressure is increased, typically occurs in patients with pulmonary hypertension due to left heart disease and also in group 5. And the combined one, again, some of the cases of group 2 and group 5 have combined precapillary and post-capillary pulmonary hypertension. So this is a typical two-dimensional echocardiographic appearance of a patient with pulmonary hypertension. The right ventricle is markedly dilated. The left ventricle is compressed. The interventricular septum is bowing towards the left ventricle during systole and diastole. The main pulmonary artery and the branch pulmonary arteries are dilated. You can see the left ventricle and the left atrium is dilated. The interatrial septum is bowing towards the left atrium. There is significant tricuspid regurgitation. And if you look at the tricuspid regurgitation velocity, it is 5.8 meters with a gradient of 136 millimeters of mercury. In the IVC, hepatic veins are dilated and no respiratory variation. This is a typical finding in patients with pulmonary arterial hypertension. This patient has got actually a condition called idiopathic pulmonary arterial hypertension, otherwise called as primary pulmonary hypertension. So echocardiogram, what can it give? It can assess the right atrial pressure. It can assess the pulmonary systolic pressure, pulmonary diastolic pressure, mean pressure, LV filling pressure. We can, of course, measure the RV stroke volume, pulmonary vascular resistance. We can assess also the RA-RV size and look at the RV function. The one thing we have to remember is the pressures are not exactly measured by the Doppler. Suppose the, say, RV pressure is calculated is 80 millimeters, it will not be exactly 80. So not everything that can be counted counts, and not everything that counts can be counted by echocardiogram. And mode echocardiography, those of you who are doing it may be aware of the findings. That is a normal A wave and normal opening of the pulmonary valve. Here you can see the A wave is absent and there is a notch in the pulmonary wave pattern during systole. When the A wave is reduced, the mean pulmonary artery pressure is between 20 and 40. And when the A wave is absent and there is a mid-systolic notch, the mean pulmonary artery pressure is more than 40. That is one of the findings which we used to discuss during the mode echocardiography days. And it was Liv Hartley who described the say, assessment of the right ventricular pressure and pulmonary artery pressure using the tricuspid regurgitation and the pulmonary regurgitation velocity. She used the modified equation to assess the gradient across the tricuspid band. So, but later it was found out that the accuracy and precision of echocardiography versus right heart catheterization for assessment of pulmonary hypertension, even though echocardiography is able to give you the diagnosis whether pulmonary hypertension is present or not, in a given case it may not exactly measure the pulmonary artery pressures. So this was again discussed in one of the editorial comment, and see the success of deciding about pulmonary hypertension, measuring the velocity, we have to go methodically what we do in aortic stenosis. We go methodically, look at the LVOT diameter, P1, V2, etc. It's like that we have to go. First, we will take up the right atrial pressure. So if if inferior vena cava is dilated more than 21 millimeters of mercury, and during inspiration, expiration, the variation is less than 50%, then the RA pressure is elevated, and it is between 10 and 20 millimeters of mercury. We usually add a RA pressure of 15 for these patients. IVC dilated, almost no variation during systole and diastole, during expiration and inspiration. Here the IVC size is normal, and the variation is more than 50%. So the compressibility index is more than 50%. The RA pressure is normal. The pressure is between 0 to 5, and we add a pressure of 3 millimeters for the right atrial pressure. Anything which doesn't fit into this high pressure or the normal pressure, if we assess that the RA pressure is between 5 to 10 millimeters of mercury, and we add 8 millimeters. So here afterwards, follow this one only. So if the RA pressure is completely elevated, markedly elevated, as indicated by dilated IVC, no respiratory variation, add 15 millimeters. If the IVC is completely normal with normal compressibility, add 3. And if it is not fitting into these two group, then add 8. So this is how we have to assess the right atrial pressure. How to assess the RV systolic pressure, which will be equal to pulmonary artery systolic pressure. So this is the TR velocity is measured by using the continuous Doppler, and 4 into velocity square will give you the gradient across the tricuspid valve. To this, we have to add the right atrial pressure to get the RV pressure. Here it is 4.3, gradient is 72, adding 15 will give you RV pressure are equal to pulmonary artery pressure of 87 millimeters of mercury. The pulmonary artery diastolic pressure can be measured from the end diastolic velocity of pulmonary regurgitation. So if the patient has a pulmonary regurgitation, if you are able to clearly measure the end diastolic velocity, then you can use the same formula and add the RA pressure to get the pulmonary artery diastolic pressure. How to assess the pulmonary artery mean pressure? There are 2 or 3 methods. So here, using the TR velocity, we can trace the TR velocity and get the mean gradient across the tricuspid valve. So the mean gradient is 38. To this, we add the RA pressure, get a gradient mean pressure of 53 millimeters of mercury. The second one is by using this formula, 0.6 into pulmonary artery systolic pressure plus 1.95. So this is the second method. And the third method, to use the pulmonary regurgitation velocity, we use the early diastolic velocity, and say if the early diastolic velocity is 3 meters, the gradient is 36, and the mean pressure is 36 plus 15, 51. So these are the 3 methods by which we can assess the pulmonary artery systolic and the diastolic pressure, and also the mean pressure. Three methods can be used. Usually there will be some variation, but most of the time it will correlate whether it is elevated or not. So now that we have measured the systolic pressure, we have measured the diastolic pressure, and we have measured the mean pulmonary artery pressure. How to say that the patient has got definite pulmonary hypertension? So if the velocity of the tricuspid regurgitation jet is below 2.8 meters per second, then usually there is no significant pulmonary hypertension. The chances of pulmonary hypertension is very low. If the velocity is less than 2.8, but there are some other supportive signs of pulmonary hypertension. I will tell you what is the supportive signs. Say if those supportive signs are present, or if the velocity is between 2.9 to 3.4, then there is intermediate probability of pulmonary hypertension. If the velocity is more than 3.4, and if the velocity is between 2.9 to 3.4 with supportive signs, there is a high probability of pulmonary hypertension. So the presence of pulmonary hypertension, you have to assess this way. Say, we have to look at the TR velocity. If it is below 2.8, most probably pulmonary hypertension is not present. Above 3.4, in all probability, pulmonary hypertension is likely to be present. Between 2.8 to 2.9 to 3.4, we have to look for other signs of pulmonary hypertension. If they are present, then it indicates that the patient is likely to have pulmonary hypertension. This criteria was, say, discussed when they were having the pulmonary artery pressure cutoff of 25 millimeters of mercury. So now that we have, decreased the cutoff limit for diagnosing pulmonary hypertension from 25 to 20, we don't know which TR velocity or that RV pressure is going to indicate that the patient has got pulmonary hypertension. We have to change this parameters also, which has not yet been worked out. It has not been discussed by the, in the pulmonary hypertension symposium. The associated signs on which we have to depend upon is if the RV, LV basal diameter, so measure the RV basal diameter, LV basal diameter, if the ratio is 1.0, and if the eccentricity index of the left ventricle is more than 1.1, these are indicators of significant pulmonary hypertension likely to be present. And look at the Doppler velocities. If you look at the RVOT velocity in the, by using the pulse Doppler, if the pulmonary acceleration time is significantly decreased, then it is likely to indicate pulmonary hypertension. If there is a mid-systolic notch like this again indicates pulmonary hypertension. If the early diastolic velocity of the pulmonary regurgitation, if it is more than 2.2 meters, it indicates pulmonary hypertension. If the end diastolic velocity is more than 1.5 meters, then again it supports pulmonary hypertension. If the pulmonary artery, main pulmonary artery, branch pulmonary arteries are dilated, main pulmonary artery especially more than 25 millimeters of mercury, again this indicates pulmonary hypertension. If the inferior vena cava is dilated more than 21 millimeters with decreased inspiratory collapse, or RA area of more than 18 centimeters square, then again it supports pulmonary hypertension. So at least one criteria from at least two of the groups should be present to support the diagnosis of pulmonary hypertension. So these are the supportive findings. It should be there when the pulmonary when the TR velocity is between 2.9 to 3.4 to support your diagnosis of pulmonary hypertension. So hereafter, don't diagnose pulmonary hypertension just like that. So it is likely to be present, or you have to report that it is present or not present, likely to be present. Or if you are in doubt, look at the other signs and try to diagnose. This come to this. So the other problem is there are technical problems with the diagnosis of pulmonary artery pressure and all that. Say the right atrial pressure itself, usually normally the S velocity is prominent, the D velocity is small. If the S velocity is less prominent, it is likely to indicate that the patient has got elevated right atrial pressure. Like E by E prime on the left side, we can use the tricuspid valve E and the tricuspid annulus E prime. And if it is more than 6, it indicates that the RA pressure is likely to be more than 10 millimeters of mercury. And in restrictive cardiomyopathy, the RA pressure is markedly increased. If there is, say, autocontrast like this, usually they say the RA pressure is likely to be 20 or more. The TR velocity is absent in 10% of the patients. So if we had in patients in whom the TR velocity is completely absent, look at the pulmonary regurgitation velocity. If there is no pulmonary regurgitation, look at the pulmonary acceleration time in the RVOT. The other problem is TR velocity full spectrum is not recorded in about 10 to 15% of the patients. So in these patients, usually we'll be able to record a TR during inspiration. Expiration, it may not be clearly visible. Raise the patient's legs. This will increase the venous return and the TR signal may become more prominent. and use the other views. Not only in the four-chamber view, you can use the parasternal short axis view, you can use the subcostal view, etc. And if the TR velocity is not clearly obtained, use a right heart contrast. You can use agitated saline or the sonoview to get a good TR velocity. So this is how in a patient with indeterminate signal, using saline contrast clearly shows you the TR jet velocity. The other thing is always measure the TR velocity during expiration. During inspiration, the RA pressure increases, the velocity decreases. So measure the velocity, the maximum velocity during expiration. And say use the number of views, apical four-chamber view, short axis view. This is apical two-chamber view, sorry, the RV inflow tract view. So use any of the views and look at the maximum velocity. The maximum velocity is here obtained in the parasternal short axis view. The other thing is always omit this feathery part of the TR signals. Always look at the brightest portion and then measure the brightest portion. This is how we say describe. Always aim for the chin and not for the beard. So you have to mark out the densest portion, the correct velocity to calculate the say systolic and the mean pressure when you are getting the TR velocity. And in atrial fibrillation, you have to take an average of 3 to 5 beats, and when the patient is, velocity is varying during inspiration, expiration, use the end diastolic velocity for diagnosing pulmonary hypertension. And in flail tricuspid valve, the valve is wide open, the velocity will be very low. In this patient, we cannot get the RV systolic pressure, we cannot diagnose pulmonary hypertension in this patient. And always, if there is a pulmonary regurgitation velocity which can be obtained, record the pulmonary regurgitation velocity, the early diastolic and the end diastolic. If the early diastolic more than 2.2 and the end diastolic more than 1.5 is supportive of the diagnosis of pulmonary hypertension. Why these problems with pulmonary hypertension? Because the mean pulmonary artery pressure records is an average of the systolic and the diastolic pressure. It is a mean of systolic and diastolic. Whereas with the TR velocity, we are only taking the systolic events. When we use the say pulmonary regurgitation velocity, you are using only the diastolic events. So none of the Doppler takes both the systolic and the diastolic components. So the mean pulmonary artery pressure calculated by the TR velocity or the PR velocity is not going to be correct, and the exact pressure, if you want, has to be obtained by cardiac catheterization. This is a correlation between the, say, pulmonary artery pressure, which is obtained by Doppler, compared to the cardiac catheterization. You can see there are some false negatives and also false positives. But most of the time, it correlates with the pulmonary artery pressure. Definitely, even though we cannot exactly measure the pulmonary artery pressure, systolic, diastolic, or the mean pressure, we can definitely come to a conclusion: this patient has got pulmonary hypertension, this patient has not got pulmonary hypertension. Also, look at the pulmonary valve and the RV outflow. So this is another patient. You can see these apical four-chamber views are normal. The velocity is increased, the TR velocity is increased, IVC hepatic veins are dilated. If you look at the pulmonary artery, here you can see there is a large mass compressing the pulmonary artery, producing pulmonary stenosis. So pulmonary stenosis, when it is present, say whether it is present over the pulmonary valve, infundibular stenosis, pulmonary artery stenosis sometimes can happen distally, and we may not be able to look at the pulmonary valve. So in these patients, we have to see whether there is any pulmonary stenosis before we commit about pulmonary hypertension. And this is how we record the acceleration time, 1 minute. So pulmonary acceleration time is normal, usually about 100 to 120 milliseconds. If it is less than 100 milliseconds, it is borderline. Less than 80 milliseconds, usually pulmonary hypertension is severe, and very severe pulmonary hypertension is 60 milliseconds. So this is the one which has been described in the 60-60 rule for diagnosing acute pulmonary embolism. And we have to look at the RVOT velocity also, and look for any notch or prominent notch during systole, which can give you a diagnosis of pulmonary hypertension. We'll discuss other things afterwards. Any questions? on the modality of diagnosing pulmonary hypertension, pulmonary artery pressure, I will be glad to answer. Okay.
Do you recommend mild, moderate, severe grading, or just say the probability as recommended by the ESC guidelines?
No, if you are sure about the presence of pulmonary hypertension, there is no harm in grading the pulmonary hypertension. So anything above mean pulmonary artery pressure of more than 40 millimeters of mercury will be severe pulmonary hypertension. Anything between 25 to 30 will be mild, and 30 to 40 will be moderate. Anything above 40 will be definitely a severe pulmonary hypertension. And this again varies in children and adults. You have to remember that.
Yes. So then, when the patient has pulmonary hypertension over a period of time, when they develop RV dysfunction, the TR velocity tends to come down when the RA pressure rises. So in that time, if we go by these numbers, like we are likely to underestimate the severity of the illness in the presence of RV dysfunction. So
the presence of RV dysfunction indicates a grave prognosis, always. If there is significant right ventricular dysfunction, irrespective of the RV pressure, the prognosis is going to be not good. That's the one. So this actually, if Triple S remembers, we started assessing the pulmonary hypertension in our early days using TR velocity. Some of the patients with sildenafil, they improved, symptomatically they improved, but when we looked at the pulmonary artery pressure, it was actually high. How the patient's TR velocity is coming up, but the patient is getting improved. Then we realized that the RV function is improving with sildenafil, and the pressure has got increased, so the patient also was feeling better because the RV dysfunction was reversing.
yes, thank you, sir.
Thank you very much, sir.